Medical Director for World Clinic, and this is your COVID-19 briefing for April 15th, 2020. Well, this appears to be the over the hump week for much of the world. That does not mean that this is over by a long shot, but it does mean that possibly much of the worst is behind us. Importantly, as I've said before, this is not a single global epidemic, but a series of linked regional epidemics. Each region of the world is affected differently based on multiple factors, including the number of infected individuals that initially brought the virus into the area, the demographics of the region, especially including age and common diseases within the region, and the degree to which social distancing and other measures were put into place, and then the timing of when they were put into place in relation to the epidemic in that area. Importantly, it is increasingly evident that the primary effect of the various control measures has been to limit the height of the peak of deaths and also the resource requirements that go with it. But it's had less effect on the overall duration, and that's not actually a bad thing. In other words, it does not appear to have just flattened out the curve, so we're going to have the same number of deaths, the same number of resource utilizations. It's simply lowered the peak. Right now, most places are about the halfway point for deaths and a couple weeks past the halfway point for new infections. Just about everywhere has seen about a 3-week run up in the number of deaths and resource use. And then it's looking like most places are seeing about a 3 to 4 week decrease back to a low level. That doesn't mean back to nothing. That means back to a low level. There's still going to be virus in the community, but it's not going to be what we've seen over the past month or so. But the biggest concern is that the peak number of cases was not as high in a completely unmanaged epidemic. Will this put enough immunity into the community to have a resistance to having a resurgence in the future? This is the concern that people hear about the second wave. Will we have something in the fall? Will we have another wave next winter? That's the big concern right now, and why we're not going to be in a position of just turning off controls until we do have something like a vaccine. So at this point, much of the world is turning to how do we reopen economies without creating this second wave of infections and deaths. In many circles, this has been termed from moving from the hammer to the dance. Now, we called it the hammer because that was a relatively blunt instrument used by governments of more or less heavily restricting all interpersonal contacts through mandated closures and even stay-home orders. Now, the dance is being named very aptly, I believe, because it's going to involve a number of forwards and backwards as we all react to how our partner in this, the virus, is working. The keys, however, to doing this are straightforward. We have to first wait until the incidence of new cases is small enough that it can be managed. This is a big importance of serology testing. I'll talk a little bit more about testing in a minute, but what serology testing is initially going to be a big benefit for is not telling individuals are they immune to the disease or not, but it's going to give us a true understanding of the rate of infection in the community. You've heard many times that we just don't know how many people got the disease and were not heavily affected by it. But that's real important for deciding how much immunity is there in the community. So the first use of serology is to understand the entire impact in the community. The next step in being able to move to the dance is to keep the rate of new infections low enough that classic public health measures can be used to limit the spread. So these measures include, how do we rapidly identify each and every new case? This means both educating the population and then also having easily accessible, rapid, and accurate and available testing for determining the presence of the virus. In some areas, including most of Asia and some of Europe, we have this already. But in other parts of Europe and most of the United States, we don't yet have enough accurate, timely testing to be able to do that. The next thing we have to have is an adequate public health workforce. That will also be combined with workplace policies and guidance that will essentially replace some of the actual public health workers so that we can effectively identify and manage close contacts of infected individuals so we can decrease the chance that they will transmit this to somebody else. Unfortunately, there's a very tight window on being able to do this. Now, I've got some math here. So try to follow me on this. The average time from infection to symptoms with COVID-19 is 5 days. And it's looking like people are infectious for about 2 days before symptoms develop. So for the contact tracing to be effective, that means we have to have same-day results to be able to identify and quarantine the next link in the chain before that person becomes infectious. So I'm going to run through this. If person 1 becomes infected on day 0, they develop symptoms on day 5, but they were infectious on day 3. So then we have person 2. Let's say person 2 was infected on day 3. They would develop symptoms on day 8, but they were infectious 2 days before that on day 6. So if person 1, the person that we first are going to be trying to go after, gets tested on day 2, the second person needs to be identified by the public health system no later than the next day on day 6 to minimize the chance that they're going to infect somebody else and continue that chain. That's what's so difficult about this whole public health approach to controlling the disease, and why we had to do the hammer to begin with. So we really have to have confidence that the existing healthcare system is also adequately robust to pick up any of the upticks in the number of cases that we'll inevitably see as the social distancing measures are dialed back. So with these components in mind, World Health and the CDC in the US are looking at communities in 3 broad groups. The first are those communities that have low mitigation requirements. Those are places that have never had major circulation of COVID-19, or they've nearly eliminated community circulation through the application of the hammer. As their peak passes and the measures we just talked about are accounted for, these communities can begin to back off on their protective measures. This process will probably start in the next couple of weeks in some areas. It's probably started in some international areas. Then there are medium mitigation requirements. The medium requirements are for the former hotspots that have infections on a downward trend. They're capturing most new cases so they can apply the public health mechanisms. And this is going to be a rolling relaxation of controls. It's probably going to begin late May, early June, and will include removing most of the stay home orders and then reopening in a rolling manner businesses, retail and food service, and schools, although given the timing in the year, it's most likely that many places will choose to leave schools closed throughout the summer. And then we have the last major area are those places that still will have significant mitigation requirements. In other words, places that we're going to have to either stay or potentially even return to the hammer approach. And this is anywhere where cases are not being controlled or they do not have the adequate healthcare resources to handle those inevitable blips in the number of cases. But importantly, in all of these categories, even the lowest level of mitigation, it's essential that basic prevention measures will have to continue until enough members of our communities are immune to the disease, either through exposure or immunization. This is the concept of herd immunity. Now, the herd immunity, the number of people in the population, or the percentage of people in the population that are immune, varies based on the type of infection. There is no one number that gives you herd immunity. Right now, scientists, epidemiologists are calculating that they think we have to reach about 70% of the community in order to have adequate herd immunity for this virus. So with that, the measures that will need to remain in place, regardless of where you are in the world, are some degree of social distancing, that's 6 feet or 2 meters. We're going to have to concentrate on decreasing workplace, shopping area, and public transportation decreases in population density. So this means that governments will typically continue to encourage teleworking, shift working, so that you have people in the offices at different times, and limitations on direct face-to-face meetings and conferences, meaning using tools such as we're using right now to be able to have your conferences rather than putting everybody into a tight conference room. There will also potentially continue to be limits on interregional and international travel. Now, that's probably going to be especially between areas that are in different of these three categories that I outlined. But because there's so much mobility in society today around the world, it's going to be difficult to determine what the real restrictions of that are going to be. And like the dance, it's probably going to dial up and down as we go forward. But importantly, the actual act of travel, getting on a plane, getting on most long distance public transportation, has so far continued to seem to be fairly safe. So it's not going to be the mode of travel that we're going to be concerned about. It's going to be transporting virus between regions. So this is all the dance. Communities may need to change categories a few times even until we have the adequate community immunity established. So there were a few specific issues that people have asked me to talk about over the last week that have general interest. The first is, what are things that people can do and businesses can do for prevention in public and semi-public areas? Let's talk about masks first. I know I've mentioned masks pretty much every one of these discussions, but it's still an important point. Masks, from a purely scientific point of view, in the general public, only add a small benefit. Now, masks are very important in medical settings when somebody actually is sick, but in the general public, they have only a very small added benefit. But because they do add that small benefit, and because they outwardly show to everyone around you that the wearer is paying attention to doing their part, many societies around the world are requiring or encouraging the use of masks. Masks, again, they're primarily effective in preventing an infected person from transmitting the disease to someone else. But anyone who has symptoms should not be in public anyway. So the theory behind wearing masks is that there does appear to be a very brief period where an infected person can be infectious, but they do not have symptoms. That's that 2-day period before they develop symptoms that I talked about earlier. While consistent studies show that this is not a major driver of the epidemic, it does make a difference. And so wearing a mask in public may contribute to eliminating this added risk. So masks will not be a huge benefit, but in looking at cost-benefit analysis, there is little downside to wearing a mask, and there is some, albeit small, upside to it, so why not? Temperature screening. So temperature screenings, like masks, the temperature screenings in public and semi-public places, and when I say that, I mean like offices and stores, from a purely medical point of view, has only a very, very small prevention benefit. Fevers come after symptoms. If people are attentive to their symptoms and they follow the instructions not to be in public if they have symptoms, then it's very, very rare that the person's only sign of disease would be an elevated temperature. But because not everyone is always open about their symptoms, or some people are not as in tune with their bodies, and because some people want to be or need to be out to continue to do their daily living activities, even if they have symptoms, temperature checks are that one extra thing that can be done to help screen out people who may have a reason not to be in that public or semi-public place. So like masks, there is some benefit to temperature checks. There really is little downside. So many regions are choosing to take this extra step and recommending temperature checks for public and semi-public places. So testing. I talked a bit about testing last week, but this is becoming an issue once again. First off, let's talk about testing for the virus. That's actually testing for the presence of the virus, typically through a nose swab. This tells you if you currently have the RNA of the virus in your nose and throat. Note that it's not saying that you have infectious particles, just that you have the RNA, which is, for lack of a better term, the payload that's associated with those virus particles. Many governmental leaders around the world are emphasizing the importance of accurate and rapid testing for any control program. Even though this doesn't mean that the presence of RNA in your nose means that you're infectious, for general purposes, we need to assume that. Unfortunately, for many reasons, many of which are related to the science and also the techniques in testing, and the realities of producing a new, highly accurate test in adequate quantities. Currently available virus tests still have a very high false negative rate. It's estimated to be 25 to 30%. This is why if you have symptoms and an exposure history, many times medical providers are not pushing that hard for a test if it's very hard to get. Save the test for those people that it's very, very important to know if they have COVID-19 or not, because it will make a difference in treating them. But because of both test reasons and the nature of the virus, a second test, if it's done the next day, can lower that false negative rate to an acceptable level. But we don't have enough tests yet, oftentimes even to do the first one, much less the second one. Until we have enough tests, we need to save the tests for where it can make a clinical difference in taking care of a patient. This is changing, this is rapidly changing, but we're not there yet. So the high false negative rate and the inability to rapidly get a test and repeat if negative is the main reason that many providers are treating based on symptoms and exposure rather than insisting on a positive test. So that's about testing for the virus. The other big test that's becoming very much in the news now is testing for antibodies. Testing for antibodies, or you'll hear serology testing, does not tell you if you are infected, only that you have been infected enough for your body to make antibodies. Well, the value of knowing that to the community is that it gives us a reasonably accurate idea of the percentage of people in the community who have had the disease and are likely immune. Importantly, that's likely immune. We're not 100% sure of the degree of immunity. How sick did you need to be to make adequate antibodies? These are things that are actively being studied right now. This is important, especially important right now, because we have no idea how many people had no symptoms or had mild symptoms, but actually had the disease or had the infection at least, and they are now immune. So if you get the test yourself and you have a positive result, you may be immune. And I say may because the presence of antibodies, either yes, you have antibodies or no, you don't have antibodies, is not enough to know you're immune. These antibodies have to be at a high enough level, and we're not sure what that level is yet. If once we know when people are immune, that's great, because people who are immune can go about their daily business without either having to worry about getting COVID-19, and you don't have to worry about transmitting it to other people. But until this testing is widely available, we're going to prioritize it to the at-risk individuals and their caregivers, schools and daycare staffs, critical personnel, including healthcare workers and staff at critical infrastructure locations. And then finally, it'll be the staff in public-facing organizations such as restaurants, retails, things like that. But a very important warning on antibody testing that you're seeing being available and oftentimes being pushed in public right now. Many of these rapidly developed tests that are hitting the market, and international organizations are allowing them to be marketed, but this is being done without completely verifying how good these tests are. There is a huge debate raging right now in both medical communities and government on how good is good enough. For my money, I'm waiting until we have a test that I can trust. And we have a test that I know when it says positive, it doesn't just mean that I've been exposed to the disease, but I have adequate antibodies that I actually am not at high risk for getting the disease. And importantly, I'm not at high risk for having it and transmitting it to my 87-year-old father or somebody like that. So I'll move on past tests. We think that major labs are coming online with reliable tests in multi-million lots. And many of these are going to be available by June, maybe even earlier in other parts of the world. But in the US, we're probably looking at June before we have these highly reliable tests that are available in adequate quantities. A couple of things on countermeasures, vaccines, no new developments that are significant in terms of timeline. We're still looking at the first quarter of next year at the earliest. Antiviral medications. Chloroquine and hydroxychloroquine continue to look like they have significant effects. Major organizations and governments, they don't want to formally back this until the good studies are completed, which is going to be later this month, probably early May. but still, many physicians have looked at the data themselves and feel it's good enough to try. Now, these medicines are not without risk, so it's very important that you have a physician who looks at your health history and looks at the medication and make sure that they're not doing more harm than good. But generally speaking, especially for people at risk, these are looking very, very promising. There are too numerous to count studies that are going on regarding other antiviral agents, and especially these are going to be focused on repurposing older drugs rather than trying to develop totally new ones. There are a number of older drugs out there that look like they may have benefit. So this is going to be important, and we're going to see things continuing to come out of nowhere, just like the hydroxychloroquine kind of came out of nowhere. Nobody expected that, but found that it worked. Been some questions about issues of air quality, especially indoor air quality. There has been much confusing press over the past couple of weeks about how long and how far a virus can remain airborne and infect people. It is becoming very clear that the RNA, again, the payload of that virus bomb, can be detected for hours and over much longer distances than 6 feet. But importantly, being detectable is not the equivalent of being infectious. That payload, that RNA, it has to be incorporated in that capsule of the virus in order for it to actually attach to your the lining of your nose and throat in order to start that infection. So studies still support that 6 foot distance. We'll continue to follow this, but the 6 feet still is looking good. So that means that's putting in special filters and disinfection mechanisms and airflow, putting in extensive special UV lighting is not appearing to be that useful at this point. There are some very promising studies that are looking at a specific wavelength of UV light that is damaging to the virus, which is good, but it's not damaging to humans. As we know, some UV light can be damaging to humans. This type of UV light is not widely available, something that I'm going to continue to watch and I'll let you know about over the next few weeks. And then finally, the last thing I'm going to talk about is this debate about multiple infections. There have been several very highly hyped stories this week noting recurrence of COVID-19 in someone who has been felt to be clear of disease. These cases have mainly been in Korea, but the head of the Korean Centers for Disease Control made a statement earlier this week that the Korean CDC does not believe this is due to reinfection, but due to a patient not being completely over the first infection. Now, what that means is still not completely clear, and there's going to be certainly more to come. So that concludes my COVID-19 update for April 15th, 2020. I look forward to talking to you again next week. Thank you very much.